Connecting to YouTube now, okay? So we may be going live any second. Yeah. You ready to go, Dr. Berli?
Yes, I am ready to go.
I'm just going to silence this. Okay. So hello, planet Earth. Thank you for joining me. This is Lilia's Weekly Wednesdays. And we are here with Dr. Jens Berli of OHSU, that's the Oregon Health and Science University, on the Pacific Coast. It's now 6 a.m. Thank you, Dr. Berli, for joining us.
Got my coffee. Thank you so much for having me.
My pleasure. So, as I said, I'm Lilia. My pronouns are she and hers, and I'm the creator of Facialteam's Facebook patient group, which has about 3,000 members. And I've hijacked Facialteam's platform to bring content which is appropriate for you, our followers. So, Dr. Berli has some interesting things to say today and share with us about the facial gender mosaic, the story behind getting FFS on the table with insurance companies, and more. So, Dr. Berli, could you please tell us a little bit about yourself before we get going?
Yeah, of course. My name is Jens Berli. I use he, him pronouns. I'm a gender surgeon in Portland, Oregon, but originally from Switzerland. My mother's from Denmark. I moved to the United States in 2010 and kind of did my plastic surgery training and then joined OHSU in 2016 with a sole focus on gender surgery, performing facial feminization surgeries, and then chest and phalloplasty. So kind of that's my focus and my passion. So thanks for having me today.
Our pleasure. Thank you for joining us at this early hour. Although we were just commenting that you're very accustomed to this time of the day, being a surgeon, has to get into the OR very early in the morning. So before we get started on the topics that you're going to present, I'd just like to talk a little bit about the collaborations that we've had in the past, Dr. Berli, with Facialteam. So for example, maybe if you could tell us a little bit about some of the publications that you have joined us on.
Yeah, so with the facial team has really been kind of instrumental in setting up a lot of the kind of the teachings and also the kind of the basic foundations of facial feminization. I mean, originally these procedures have been developed by Dr. Austerhout in San Francisco, but the facial team has really brought kind of that kind of academic aspect to it of really studying, outcomes from, large cohorts of patients and also with a focus on teaching and advocacy within the field, which I think is a really, important part of what we're doing, because as we'll get into a little bit later, these surgeries have not always been covered by insurance companies, and on large that has been because the standards of care version 7 by WPATH did not, firmly state that they're as medically necessary as other aspects of gender surgery. And so one of the projects we did was reviewing a systematic literature review to kind of see where we're at with the evidence on facial gender confirmation surgery. And so I see that you're frozen right now, so I don't know if you can still hear me. I'll give
technical problems.
I can hear you again.
I'm here on the other screen. Sorry, I'm having a technical problem with the other computer, so it's a good thing I've got two.
But you heard everything I said?
Hang on one second.
I see there's a chat, so anyone can write in the chat if they heard everything I said.
I'm sure that they can, because I believe we are still streaming. So let me just, okay. Yes, we're still live, Dr. Berli, as far as I can tell.
Perfect.
Okay.
I think in 2020, we're all accustomed to technical glitches with Zoom and all. So yes, I was just summarizing to the people on the call that a big part of our collaboration has really been in terms of advocacy and also setting up teaching courses so that we can train more providers. So that's been a big focus of our collaboration.
Exactly. Thank you for that. And I couldn't hear you for a brief moment there, so I don't know if you mentioned also the workshop that's coming up in March.
I have not yet mentioned that one. I'll leave that up to you.
Okay, okay, we'll talk a little bit that later. So yes, we've got some training things planned in the future as well, which we're very pleased to have Dr. Berli on board for. So in regards to our discussion topics for today, as Dr. Berli mentioned, first I would like to backtrack a little bit also. Can you tell me what exactly is a gender mosaic? Because I don't think many people know what it is. If you could give us a definition.
Yeah, I mean, it's more a concept than kind of a real kind of established thing that it's just something that I've noticed when I talk to the patients that I see for consultation the first time. When you, as a surgeon, when you evaluate a patient, it's photograph is one thing, but when you sit face to face with a patient, usually, of course, it's best to then kind of course that also works over real kind of video call. But really seeing how a patient's face is moving, how they're talking, how they're smiling. I mean, there's so much dynamic aspects to a face as well. So that kind of all goes into the evaluation, and it's not just about looking at what testosterone has done, but also really seeing what are the feminine traits that someone has, both in their dynamic expression, but also from their structural components of their face. And since we all are really, I mean, the predominant factor that kind of comes in during adolescence is the testosterone, right? I'm sure some of you may have seen, the kind of when you have two twins and, they grow up, they're, let's say 11 years old and they, look the same. And then, one person gets on testosterone, the other one doesn't, or gets on hormone blockers, whichever way that goes. And then you can just see how that affects the changes of the face, and they kind of, separate their appearances. And so when I look at a patient, I try to find what are the aspects that are feminine, because we all have feminine and masculine traits on our faces. And so that's usually how I start the conversations with my patients, asking them, what is it that you like about your face? I think that's really important. And sometimes patients get taken a little bit aback by that question because they're kind of coming in with all the things they don't like. But I do like to talk about the positive aspects of their faces. And some patients say, well, I don't like anything. And in which case I like to point out what I see that is feminine. And a lot of patients feel that can be very affirming. And other patients tell me things that they, like about their face, and it doesn't even have to be masculine or feminine, but it's just aspects they like. And I think that's really important as a surgeon to hear and listen to, so that we don't approach, surgery just as a kind of a cookie cutter. Well, you got to have forehead, nose, this, that. This is just kind of what you need to have in order to be feminine, because that's not the reality out there. And I've prepared a couple of slides that I'm, maybe be able to show you here. Let me see if I can screen share this. If you allow me to screen share.
Yeah, I'm opening that now. There, you should be able to screen share.
Okay. Can you all see this?
Yeah,
Perfect.
I can see it.
So, these are just photographs taken from the internet. And so you can see this particular individual. It's really hard just to tell from this photograph. But, most people get just asked on the street, you would say, most likely this is someone that has not been exposed to testosterone. But if you put the whole face together, it becomes more clear. But same thing with this photograph. You could say the upper lip could use a little bit more volume. Maybe the upper lip length is long, that gives that away. And, you could see some hair follicles. But all in all, this looks very feminine. But of course, if you put the whole face together, it becomes clear with the low set eyebrows and, the distance from the upper eyelid. to the eyebrows, and all the things that we all know about. Same thing here. This is Brad Pitt. This photograph. So you can see there's, just piercing out what are the things that are feminine, and kind of focusing on that. And then we can build from there and start reducing the areas that have been, affected by testosterone. And then there's things that I also find is really important to tell patients. There are things that, maybe we think of as being, masculine or feminine, or certain ideals that people are having, where they say, well, this really V-line kind of jawline is super important to me, when a patient comes and says that. And that might be true, but it's definitely not something that defines whether or not someone is masculine or feminine, as you can see from this photograph. So you can see that, for example, Angelina Jolie's jaw is more square than Brad Pitt's jaw. So just kind of removing the angles, is per se, not necessarily going to be the right thing for any given face. So really analyzing each face, what is it that they need in order to kind of get to that feminine appearance that patients want to have. And as you can see here, other examples, again, you can see here Gwyneth Paltrow with a rather kind of square jaw. So again, it's a very individualized kind of assessment, and to kind of figure out what is it that we need to do for any individual patient. Let me stop share here.
Respect for all. I like that.
There we go.
Thank you, Dr. Berli. That was very interesting and a very complete explanation of what the facial gender mosaic is. So I think everyone now will understand a bit more. Apart from that, you talked about the first thing that you asked patients, and I think that's really interesting and important. And Facialteam also has the same custom of asking patients, what is it that you like about your face, and what is it that you don't like about your face? Because it's about working together, isn't it, to find the optimal surgical plan. So how do you explain to your patients and their parents or partners what internal and external dysphoria is? That's another topic that you wanted to discuss today.
Yeah, so I'm not sure I use these terms, they're a little kind of simplistic, but I do feel that people come in with a kind of a certain desire of, feminizing the anatomy they have, right? And usually because of the exposure to testosterone. Now, life is more complex than just that, right? And so I see patients that kind of come in and say, well, I actually, all in all, like my face. Like, if it wasn't for societal discrimination, I wouldn't want to even have surgery, because I am pretty aligned with myself. I've accepted myself the way I am. This is not the source of my stress, but it is really just, I fully transitioned. And when I go to the store and just being out and about, that constant stress, be that very overtly being discriminated against or harassed, or even just microaggressions, that is really wearing me down. And so that's why I want to have these surgeries. And on the other end of the spectrum, there can, be people that have not so much of an issue with, how they, are perceived in society. Maybe they live in a very affirming, environment, but it's how they see themselves in the mirror that really is what kind of triggers them. Every time they look in the mirror, there's this incongruence, and that just that gives them, the distress. And so, most people are obviously somewhere in the middle and have some aspects of both of these things. But I do think it's important also to, talk about that, because, while these surgeries can go a really long way, in some patients, more than others, depending a bit on your skin type and, other anatomic, aspects of your face. And so it doesn't always achieve the full goal of congruence when you look in the mirror, or it doesn't always achieve, even in a very good result, it may still lead to misgendering at times. And so kind of having that conversation to establish not only surgical goals, but also, outcome goals for, the sensation of gender dysphoria, and how are these surgeries gonna, ameliorate the issues that you bring to the table, and how much can we, achieve those goals so that we can set realistic expectations, and not have, the disappointments, afterwards. So I think that's really important. I want to, I'm going to share my screen again. I have another.
Sure, yes, please do. And I just wanted to comment on what you were just mentioning about having realistic expectations and how important that is. I'd like to highlight that and also invite any of our viewers to write into the chat any of your questions or comments. We're happy to incorporate them into our discussion today.
Yeah, so this slide I wanted to show here is more something I use almost for all of my talks, especially professional talks, when I present to an audience that may not be familiar with gender dysphoria, may not be familiar too much with the surgeries, because I think it's especially, I think we all know that there's been, studies that came out in the, like decades ago that demonstrated, well, these surgeries, while patients may be happy, but they don't work, right? And because patients still have suicides and this and that, and the studies were all really performed very poorly. Some of the outcomes measures were discriminatory at best. But then I think one thing that often gets forgotten in this whole mix is the setting where, where these surgeries happen, the setting where patients live in. And so this is kind of the way I think about gender affirming care in general. And that's not just about surgery, but just in general. So you can be in an environment in a country, or that can be, the village you live in or the city, wherever that may be, where there's no provider and there's no understanding or acceptance of transgender and gender nonconforming individuals. Then you can have an affirming provider, right? So, and this is kind of where the United States was for a very, very long time, where there were, a handful of providers, across the country, usually in private practice predominantly, with fee for service. And, those providers, or like the facial team, right? It's a small little nucleus where someone is offering services. But if the patient, let's say you're trans feminine, you get a chest feminization surgery, and then you go out into this non-affirming environment, you might get harassed even more than before, right? So, your mental health could get worse, not better. But that doesn't mean the surgery wasn't right. It just means that, that the environment didn't, accept you. And as such, it's no surprise that people might get even more depressed if they go to the gas station and, they may not have access to facial, feminization surgery or other factors, and just get harassed even more. Then you can have an affirming team, that's more like the facial team, where it's not just a provider, but you really start having, maybe there's a hormone provider and there's a surgeon that are offering these. And the same kind of issues can come up. And then the next step up, when we're talking about, where I work at an academic hospital, having an affirming hospital, which means gender neutral bathrooms, use of pronouns, and teaching everyone in the hospital around, affirming care. And that gets increasingly more complex as the hospital size gets larger. And so, for example, the hospital I work in, I think we're over 20,000 people working here. So there's a lot of teaching you have to do to really set up a hospital that is affirming as a whole. And then the ideal is, of course, to have an affirming hospital, or even, a healthcare system, not just an individual hospital, within an affirming society. And I would say that the outcomes from gender affirming surgery and hormonal care in all these aspects is going to vastly differ where on this ladder, you receive that care.
Absolutely, Dr. Berli. This is a very clear representation, what you've just shown us, of how complicated it all is and complex. And I shared in the comments now a link to a post which is on our blog about adjusting your expectations and how important that is, and being realistic about the outcomes. And so I really liked what you just showed us. That was excellent. To move on with because I know that you're very busy and you have lots of things to get done before 5 a.m. Sorry, before 7 a.m. So when we talk about insurance, right? This is a hot topic now, especially in the US. A lot of people assume that it's easy to get something like gender affirming surgeries on the paper, right? And the codes for them. There's a whole laborious process just to get recognized by insurance companies. So I know you have a lot of insight into that. Can you share that
Yeah,
with us?
yes. I mean, that is, probably one of the most important topics, right? I think maybe stepping one step back, what does it take to be able to provide care for this population? And so I think thinking of it, people that call in or listen into this, you're obviously an individual, right? And you fend for yourself and you try what you can to kind of get the care that you need. But for me, what I think about is the entire population of patients that have not received care for decades. Now talking about the United States, but that is also true for many European countries, especially if you have a single payer system. There might be one center with two surgeons, and that might not be enough to serve the entire transgender community. And if we take the assumption of having 0.5 to 1%, whatever number is out there around the estimate of how many patients do suffer from gender dysphoria or are transgender, then that's a lot of people. Doesn't mean everyone, as you know, not everyone needs surgery, not everyone wants hormones, so not everyone even has gender dysphoria. So it's a mixed bag, but be it as it may, there's a lot of patients. And so what are the barriers to getting the services that you deserve and that can help treat your dysphoria? It's having a provider or a hospital that actually offers that care. And with that comes having trained providers that are knowledgeable and have experience within the field. And so now I'm talking a bit more in terms of the United States. So this is kind of one big barrier that still exists, right? Because in residency programs, this has not been traditionally taught. And so, this is different now. For example, in my program, I'm the residency program director here at OHSU, and we have 15 residents, and they spend 6 years, part-time with me. And so over the course of their training, they actually get fully trained in these surgeries. And, then I have a fellow now. And so that person can go out and then also teach more people, right? So, but this is a slow moving train. It's not going to happen over the course of 1 to 2 years. So this is going to take a decade to really be able to have enough providers that we can cover the entire United States. And so that's a barrier, right? And then the other barrier is insurance access. So having an insurance that actually covers these procedures. And so that all kind of goes hand in hand. The more insurance coverage there is, the more likely, academic institutions will, have set up, those centers, because as an academic teaching institution, you're not going to be able to provide these surgeries if, most people that will pay out of pocket, they're going to go, to Spain, or they're going to go to their local private practice plastic surgeon. So insurance coverage is an integral part of bringing this really into the teaching fold, into the academic realm, so that, so I think these two things really go hand in hand. And so now when it comes to the insurance landscape, there's been, this has been covered in many European countries under the kind of the overarching kind of what is covered under our national health plan. Every country is very different, so I can't touch about all the nuances, but and then again, there's the question in these systems, what are the requirements? So a lot of European systems have a lot higher standards of care than what WPATH recommends. So in some countries that can be, you have to go to a certain clinic for 2 years, or you have to do this for that amount of time. So because they don't have enough providers, and they don't have enough resources, and any healthcare system is strained for financials too, they set up higher barriers, right? In the United States, we're kind of fortunate that most insurance companies that we work with kind of adhere to the standards of care of WPATH. So that's a kind of a benefit. And so those standards of care that were in the version 7 really commented on the fact that chest masculinization, bottom surgeries, those are considered medically necessary. But facial feminization has been kind of term that could potentially be medically necessary in an individual patient, right? And insurance companies, they don't necessarily want to, increase, access, right? So they will take that sentence and, be like, well, it's not it's not medically necessary. It's essentially what we heard. And so common sense, as you all know, I'm preaching to the choir, right? Like the face is what you carry out into society. So how can that not be, one of the most important aspects of gender affirming surgery? And that's really kind of what I think, the facial team and, myself and, other surgeons like Devin Kuhn at Hopkins, and, we all kind of were scratching our heads because it does not make logical sense. So, looking at taking a step further, and this may be slightly technical, but I think it's important because medical necessity is a buzzword that, patients come in to me and say, well, but this is medically necessary for me. It could be a lower eyelid blepharoplasty that, like, well, but, this will feminize me having the lower eyelid done, and it is medically necessary. And there I sometimes do have to pause and say, well, medical necessity is not completely an undefined term, right? There is like a certain language behind that. And so I'm gonna get a little bit technical, but I'm gonna share screen again on that.
Perfect.
So, as an insurance company, it depends again on the market. If it's a single payer, it's very different. But if you have a private insurance company market, insurance companies decide what is it that they want to cover for any given plan. And someone can have insurance company A, but the money comes from your employer, like some big company that pays the insurance company. That can be a very different package than someone that gets it through a different company. So it gets really complicated. But essentially what it boils down to is a coverage decision, a policy decision where the insurance company says, this is what we're going to cover, right? And then also medical necessity. And I will talk about how do you establish medical necessity? And this is where a lot of providers and patients sometimes get frustrated, right? Because just because something is medically necessary does not mean the insurance company has to cover. It does not mean that, a country has to put that into their benefits package. For example, in Oregon, we have our Medicaid plan. They have a very clear, like, this is all we cover. So, I have a friend of mine who has like a big ganglion on her wrist that causes her a lot of pain and grief, and she has a hard time working, but that is not covered through the Medicaid plan because it just says, yes, it's medically necessary, but it's just not above the line that we want to, that we can't afford. So there are these realities, and I think we all just have to accept that there are some of those barriers, and sometimes we can appeal, we can help fight it, but there is some reality to that. So I think that's important to note. Just because something's medically necessary does not mean that an insurance company necessarily will cover it. If something is, in the professional literature considered not medically necessary, then it's very unlikely, and that is where facial feminization has been. But as with the standards of care 8, this will be changed. And so I think this will, facilitate a lot of the conversations that we have with insurance companies. So medical necessity, how do, you think about it, right? It's like, the gender congruence, what we talked about before, the misgendering, societal stigma, all that comes with it. I don't have to explain that to this audience. But the way that insurance companies think about it is there's these kind of 5 things that have to be established. So the decision-making authority is like, who says that this is medically necessary, right? And so for facial gender confirmation surgery, this will be, of course, the patient has a voice in that as well. But it's going to be, in a more legal terms, it's going to be the medical provider, and then the medical director of the insurance company. And then, what is beneficial is also having the mental health professional, right? Because it's, as providers, it is how does this affect your mental health and how you function in society. So because at the end of the day, medical necessity will always be decided for an individual patient. And so the mental health aspect in this, not to determine whether or not someone is transgender, but really determining how does this affect you. And so that's going to be an important piece. And I think it's important for folks to realize that mental health letters will be part of that if you go through insurance, and should be part of that. Again, not with the intent to question who you are, but with the intent to figure out what is it, where are you at with your mental health in terms of as it relates to the intervention that we plan. Then the purpose of the intervention. to kind of making sure that that it kind of aligns with again, that's where, you know, a letter is it what we're doing really treating what someone is suffering from, and that purpose does require, you know, still a medical diagnosis. Then
A
the scope of,
justification.
yeah, then the scope of the intervention, right? Has everything else that, you know, has everything else been exhausted? Are there cheaper methods? Are there other methods that are less invasive, meaning less risky? Have they all been tried, exhausted? You know, or is there evidence that they wouldn't work? And then that brings me to the most important part, which is the standards of the evidence, which means, is there scientific support for what we're offering? And that is where the big stumble block was for a long time, and still is to a certain degree, right? You know, you can't just be like, well, this is a treatment I've heard of from a friend, and I'm going to offer this to this patient, and I think it's medically necessary, right? I'm going to have to be able to say, hey, you know, the facial team has done, you know, 400 of these, and this is the complication rate, and here's the patient satisfaction. Here is how it affected their mental health. You know, ideally, here is what we've learned as a professional community, what this can do for someone. And so that's the cornerstone really of all of this. And that evidence was just not as strong before the standards of care version 7. And that has been a focus in the past decade of, you know, places like the facial team and, you know, and other surgeons of really establishing that literature so that we now have really a strong ground to stand upon. But that becomes facial surgery. There's so many things in that, right? So it's not like chest masculinization is so much easier. You're just, yes, you remove the breast tissue, relocate the nipple areola complex, you masculinize the chest, but it's kind of one surgery, right? There's not like a lip lift in there, facelift, if you do a jawline contouring, but then afterwards you have loose skin, does the facelift then also belong to facial feminization or not? You know, those are really complicated questions, and we don't have that evidence or that literature, right? So what we do really have is the effects of testosterone on the structural aspects of the face. So forehead, nose, jawline, you know, laryngochondroplasty or Adam's apple reduction. Those are kind of the areas that we have really good kind of data at this point. And the other things are still in process. So then it really depends on your insurance, you know, coverage. So whether if the insurance company says, yes, we offer facial surgery, but that doesn't mean, yes, we offer everything in facial surgery. So that's going to get complicated again. And there's going to be frustrations from folks because the insurance company say, well, we're going to do the frontal sinus setback, the forehead feminization, but we won't cover the cost of a brow lift. And so those become, you know, difficult conversations because, for example, as a surgeon, I'm, you know, kind of stuck there because if I do a brow lift as part of my surgery, that adds time. But I'm already there. It's not a lot of time, but like if I omit that from my operative note, then I'm essentially committing insurance fraud because the OR time is longer and the insurance company is going to pay for that, even though they said they're not going to cover brow lift, right? So we're going to get into some of these rather complicated, you know, scenarios. So I'm really glad to be able to kind of share this with you so you understand a bit where we as surgeons are when, you know, in which, you know, reality we live and, you know, that we have to deal with in order to be the best ally for you that we can.
And it's not always easy, is it? Because you have to work within a framework.
Yeah. Which is, of course, easier if you're in, you know, private practice and there's a certain amount of, you know, you say, well, this is what it costs if you come here. But as a lot of patients out there are going to go through insurance, you know, this is the reality that we live in. And then the last point is value, cost effectiveness. And all in all, those surgeries are cost effective because it's a, you know, usually 1 or 2 time intervention. It's not a lifelong ongoing kind of cost. So I think that's easy to prove. So that's, you know, I know that was a bit technical, but I think it's important so that when we, you know, throw around the word medical necessity, that we understand there is, you know, some structure to that term.
I just want to ask a quick question. When you say medical necessity, would you consider that a synonym of essential surgery? Because in the pandemic, when a lot of places had to limit the types of procedures that they were still doing, and procedures, gender-affirming procedures were one of those that got put on hold for a time. And so there was an uprise about, hey, this isn't, we are also, this is medically essential or necessary for us.
Yeah, I'm so glad you asked this question, because I sometimes want to bridge a little bit because I'm an ally of the community. I work, this is my day-to-day life. I mean, I spend almost every day of the week, working in this field. So I'm very passionate about it, but at the same time, I also understand kind of, some of the, how healthcare works, in a different realm. And the issue is that, rightfully so, a lot of folks have, traditionally been discriminated on against by healthcare. There's a deep mistrust to healthcare in general. They, might trust an individual team or provider, but as a whole, there is a lot of mistrust, which is absolutely legitimate based on the historical, the history we all know. Now, when it comes to this pandemic, this was, and also at our hospital, like elective surgeries were put on hold, and elective surgeries really included people with active cancer, people that are on the cardiac surgery wait list, but it was not considered, you need to have this surgery next 2 months. But, so it was just treated, honestly, as, I of course, only really talk from the aspect of my hospital, but it was treated just like any other kind of medical condition. And that is, that the surgery, itself, for the gender dysphoria. So that was actually kind of, I felt like what we want, right? We want this not to be some kind of outlier in medicine, some kind of, oh, what are they doing at that hospital? This should just be a regular part of medicine. This is like any other, patient that comes in and has an ailment and needs a treatment or whatever it is. This is just be treated just as such. And it was during, the pandemic, at least here, and we restarted the surgeries the same time that people got their, their other breast cancer treated, or whatever the surgeries were that were deemed okay to wait for 2-3 months. And so I think it's important to clarify that, just because it's something wasn't considered an emergent, need, that wasn't like classified differently. But I did understand that a lot of patients got really, stressed out because they felt, well, sorry, you have a question?
Yes, I have a question. One of our viewers is asking if you have had any patients with federal insurance, federal employees, government employees approved for FFS coverage at your hospital?
I have that particular scenario I have not had. I'm not too savvy around if someone is a federal employee and working in, for example, in Oregon or other state, what exact insurance they go through. But I've had patients, but that's not within facial surgery, but for example, coming through the kind of military systems or, other insurance avenues that are considered federal.
Okay, and there was another question from one of our viewers, and we're talking a lot about gender affirming, but really with people who are undergoing a gender transition in mind. And I wonder what your feedback is on if, is it common for what people call cisgender women, no, to undergo FFS in case they find their faces are not feminine enough? Would that be medically essential?
No, so, that's where I think a lot of people, it is a little bit of this difficulty, right, between parity. So yes, there are cis females that may have a large nose and be very distraught by it, right? Or similarly, on the cis male side, you can have cis males with gynecomastia that are extremely distraught by having, a kind of feminine appearing chest. But those things are not covered for cisgender. And that's an argument that's frequently brought up, is like, well, but, we don't do this for cis, folks. And, in an ideal world, we would live in a society where where there would be, just an abundance of, healthcare and money, and we could just do whatever anyone really suffers from. But, there is a financial limits to what we can. And so we don't do that for cisgender, but I do think there is a distinct difference, right? Because as a cisgender, female, if you go to a store, yes, you may have a very masculine nose, and maybe your internal sense of self may also be really kind of, affected, but you're probably not going to get arrested. You're probably not going to not get your job. You might not, on a bus be, harassed and discriminated against. So it's a very different experience. And not to say that there couldn't be some individual out there that has that kind of experience, but again, I think it's important that we take the individual experience away, because as healthcare, you have to think about population, right? So as an overarching population, it's really not comparable. And that's also the argument that is used to say, well, for the transgender population, it is medically necessary. We can't establish that for the cisgender population because we don't have the data, but we do have the data for the trans population, right? We do. So.
Right. Well, thank you for that very comprehensive answer. You're so good at it. All of your explanations are fantastic, Dr. Berli. I have no doubt that people who come back to watch this video will find it a wealth of information in their journeys. So just to summarize a little bit, everything that we've talked about, you've commented on the importance of science, the science, that's the research that is making FFS, establishing FFS as a medical necessity in a way, and also the role of, although some people, as I've heard patients complain of WPATH as being a political institution, but it does have a role in moving forward the field and getting the field of FFS and other gender-affirming surgeries in the political realm, which is important, as you talked about, for insurance coverage purposes. So is that so far good, a summary of what we've talked about in this live?
I obviously can't speak on behalf of WPATH, but you're exactly right. It's a lot of the world is complex and complicated, and in order to move our field forward, which I think we can all agree that the past decade has really changed the way that people have access to care, and it may not always be as fast as people want, because you only have one life, right, and time is passing. But thinking of the kind of overarching where we were and where we are now, I think we can all agree it's come a really long way, and WPATH has been kind of at the center of that, and has gotten also, is listening to the community, and a lot of community members that are engaged in WPATH, and to make sure that we're all pulling on the same string. I think we've seen it with just the political situation in general here in the United States. Most, we do work best if we work together and not have too much, kind of infight around top, controversial topics. So I am very optimistic about the future of, the way that we all work together to kind of get this field even further.
Absolutely. And would you just, to close before your takeaway message, I'd just like you, if you could, to specify what your role is in the SOC 8, the Standards of Care 8 revision. Which work group are you on? And Facial Team's on the surgical group, and I understand
we're on the same team.
Okay.
Essentially, there's different subcommittees that are just looking through the various aspects of gender surgery, but it's not, again, it's a kind of a rigorous process in terms of the entire scientific body of literature is being reviewed, not just me as a surgeon sitting there looking at it, but actually by people that have an understanding of how do you systematically truly review the entire literature, and what are the things that we can definitively say at this point in time, and what are the recommendations based on those to establish what we call kind of best practices. And I think it's fair to say that facial gender confirmation surgery will be elevated just like any other gender affirming surgery.
Yeah, up until quite recently, the focus has been more on body surgeries, right? And facial gender feminization in particular is coming more to the forefront, and the WPATH standards of care is integral to help make that happen on both the political plane and within the insurance provider circles, right?
Absolutely, but again, I would say it's important to with these kind of documents, just make sure that everyone understands. Again, it is based upon the scientific literature that we have. And so while it is then can be used for whatever political, way that we want to move something forward, it is not a political statement, it's not a political kind of, it is a professional expert opinion combined with the scientific literature, where we are today, what are the recommendations based on the knowledge we have, in this time. And that's why it's being revised every 10 years, because things change and our knowledge expands, and then we change it again.
Absolutely. And I thank you so much for your participation in the field and in all of the hard work that goes behind working on that document, the standards of care, which is in process, and we hope to see it soon. So I'm glad you clarified those points, because I think it's important. So, yeah, for people who want to contact Dr. Berli through the OHSU website, perhaps, and is there another way that people can follow you?
So I'm not that big on social media, because I don't have enough time for it, and it takes too much time. So yeah, so it would just be, the OHSU website.
Great. You can find the link in our description if you're watching this video. And now, Dr. Berli, if you could just give us a little takeaway message, what would you like people to remember from today's discussion, and any well-wishing that you would like to share?
Well, I mean, at the end of the day, it's the end of the year. So first and foremost, I think we all had a rough year, each individual person, depending on where they are, were, on top of life already being complex. And I think life is, not easy for anyone, irrespective of gender identity or any other kind of traits. I think we're all on this planet together, and sometimes that gets forgotten, that we're all going through this life experience. And so just wishing everyone a best of 2021, and we'll keep going.
Exactly. Thank you so much, Dr. Berli, for joining us again today. If you're watching this, please put claps down in the comments. Let us know your questions. We do respond eventually to all the messages we receive, even if it's not actually during the live stream. So don't be afraid to let us know if you have further questions. I really appreciate your participation again today, Dr. Berli. We've got some people clapping here. And also, I'd like to say, if you are interested in staying in touch with Facialteam, please join us for our monthly newsletter. I've just put the link down in the comments. And please also like this video, share it, and see that button down there, the red one? Follow us. Follow the channel and keep up to date with the lives. We're mostly weekly. And yeah, so I don't have a live next week. Sorry, folks, but well, I might pull something out of my sleeve. We'll see. But at the moment, there's nothing planned, but definitely we'll see you in a fortnight, because I have an author of workbooks for the parents and family members of trans people. And they're very handy, and the author DM Maynard is going to be with me in 2 weeks' time to talk about this, and she's actually going to become a regular here on Lilia's Weekly Wednesdays. So and we want to make sure we're reaching not just people who are interested in transition, but also the people who support them and their allies. So that's why we're bringing her on board. So thanks again, Dr. Berli. Kisses all the way over to the West Coast from Europe. And thanks, everybody. Stay safe, keep well, and remember, your healthcare and happiness matter. See you soon. Bye-bye.